Let me ask you a question. In your clinical pediatric practice, have you come across patients, mostly adolescents, who have got a myriad of strange symptoms? They usually complain of palpitations, they complain of their heart racing, they complain of anxiety, they complained of some form of difficulty in breathing, they complain of brain fog or as if they are walking over the clouds, they complain of numbness in their body, and with all these symptoms, their examination is absolutely normal. And then you're scratching your head that what could be the cause for these strange symptoms? Now, you might say that yes, we do see these types of cases. And let me tell you, at least I see these cases on a daily basis. And for some reasons, since COVID, in the last 3 to 4 years, I am, and probably you would also say the same thing, that we are seeing more and more of these cases. So, what is all this? What is this condition which presents with these strange symptomatology? So, today we will try to solve this puzzle. So, let's dive in and get started with today's topic, and that is POTS. 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 What does that stand for? Now, this is not the POT disease or the POT disease of the spine. This is POTS. And this acronym POTS stands for Postural Orthostatic Tachycardia Syndrome. Postural Orthostatic Tachycardia Syndrome. So, as the name says it, is related to posture, upright posture. Orthostatic, it is related with some form of orthostatic intolerance. Tachycardia, obviously, one of the cardinal features of this condition is increased heart rate. And syndrome, because we don't know exactly what causes this. It's more of a spectrum disorder where different people would show different types of symptoms. So they may be anywhere on the spectrum. Now, to begin with, let's talk about the epidemiology. This poorly understood condition has been on the rise in the last 3 to 4 years, especially COVID and post-COVID times. We are seeing more and more of these cases. It is commonly, affecting the young population, especially the adolescents and young adults. More common in females. Perhaps females are 5 times more likely to suffer from this condition as compared to males. In other words, there is a 5 to 1 ratio when we take female to male ratio. Now, it is increasing worldwide. It's not specifically confined to one geographical location, but it is on the rise worldwide. So almost the literature from everywhere is reporting a rise in this condition. Now, let's start with the definition. Postural orthostatic tachycardia syndrome. Now, it's a clinical diagnosis, and by clinical diagnosis, I mean that it has to satisfy a few of the clinical features. So, number one, it is associated with postural tachycardia. What does that mean? It means that when a child or when an adolescent changes his position to an upright position, that means a standing position. So that's standing from a lying or a sitting position. There is an increase in the heart rate of more than 40 beats per minute. So there should always be a rise, a postural rise in the heart rate, which should be more than 40 beats per minute. This is very, very, very important. For adults, it is usually 30, but for adolescents, it's 40. So, for example, if somebody has got a resting heart rate of 80, it should become at least 120 in the upright position. If somebody has got a heart rate of 60, it should become at least 100 in upright position. So, there should be a postural increase in heart rate of more than 40 beats per minute. So, this is condition number one. Number two, it should not be associated with any orthostatic blood pressure changes. In other words, there should be no orthostatic hypotension. In other words, if you take the blood pressure of that child or adolescent in upright condition, there should be no decrease of more than 20 millimeter, the systolic, or 10 millimeter of the diastolic. So there should be no orthostatic drop in blood pressure, because if that is happening, then that is a compensatory tachycardia associated with the orthostatic hypotension, and the condition is a different one. So there should be no orthostatic drop in blood pressure. So number one, upright tachycardia of more than 40 beats per minute, absence of orthostatic hypotension, and number three, it should not be explained by any other physiological or pathological condition. In other words, you have ruled out other structural, heart, or neurological problems. So this is a clinical diagnosis. In other words, it means you have to do a bit of workup to exclude other conditions in order to make sure that there's no underlying heart or like cardiac or neurological reason responsible for this condition. So this is a clinical diagnosis. Now, coming down to pathophysiology, it's not clearly understood what causes this. There have been different theories regarding this condition. So one theory says that there is an adrenergic overdrive. So for some unknown reason, these people have got their sympathetic system running in a fourth gear. So it's going quite fast, and there is a sort of a predominance of adrenergic hormones in their body, which especially rises when they change position. Why it happens, nobody knows. It's just theory. Theory number two says that these children, adolescents, they are suffering from hypovolemia. So for some reasons, their blood volume is low. The water in their content in their body is low. For that reason, they are not able to maintain properly, their baroreceptors and chemoreceptors are not able to compensate for the changes which occurs with the change in the posture, and that's why they get tachycardia. Again, this is a theory. A third theory which has recently cropped up, they say that it has to do something with the cervical instability. So some form of cervical spine instability, the way the posture is, somehow puts pressure on the vagus nerve ganglions close to C1 and C2, and that leads to inhibition of the vagal tone. And when the vagal tone is inhibited, there would be a predominance of the sympathetic drive, and that would cause tachycardia. Another theory is that it's associated with anxiety, but it's not clear whether anxiety is responsible for this condition or whether this condition itself leads to anxiety. We don't know. Again, these are all theories. So these are some of the common theories that are in the market regarding this condition, but we don't know for sure what is the exact underlying pathophysiology. Maybe with the passage of time, as more research pours in, we might be able to know what causes this in the future. Now, as I already told about diagnosis, that if you fulfill this criteria of definition, that is also the diagnosis. So you have to do a bit of workup to exclude the neurological and cardiac reasons responsible for tachycardia. Now, coming down to the clinical features. Now, clinical features are very important. It's quite strange. It's a spectrum disorder. So not everybody would be having the same symptomatology. They can have mild to moderate to severe symptoms. The most common symptom, which is part of the diagnostic criteria as well, is tachycardia. So tachycardia can be, determined in different forms. Number one, it's a symptom as well as sign. So you, as a doctor, can determine tachycardia if you take the pulse. But because the patient is coming up with their complaint, so it becomes a symptom as well. So the symptom, tachycardia, the symptom usually presents as racing of the heart or palpitation. So this condition would be common in all the cases who present with this spot syndrome. So they will be complaining of palpitation. They would be complaining of racing of their heart. Now it might be associated with some chest pain as well. It might be associated with some headaches. Usually the headaches are occipital dull headaches, probably somewhere radiating down to their neck as well. They might be complaining of blurriness of vision. They might complain of anxiety. They might complain of what we call as brain fog. They might complain of a bit of numbness in their body, especially the limbs. They might also report that the limbs, they change color in the standing position. And all of these symptomatology is predominantly in upright position, and it decreases in severity when they are in recumbent position or when they are in sitting position. So you will see that all the symptomatology predominantly gets aggravated or is sort of, brought about by change in posture. So prolonged standing, prolonged, sort of doing something in upright position, or suddenly changing positions, and then within a couple of minutes they would report these symptoms. Again, when for the first time if they're presenting with these symptoms, you are worried that is there any cardiac reason for this, or is there any neurological reason, because some of these children, they might even collapse. They are about to collapse or they might collapse. So you might think that is there some form of atonic seizures going on? Is there some form of neurological, issue with them? So ruling out neurological and cardiac reasons is the part of the workup of these. So obviously, as a part of cardiac workup, the first thing that you're going to do is an ECG and blood pressure readings. That would be helpful to you because the ECG would show you sinus tachycardia and would rule out structural physiological heart problems like supraventricular tachycardia or arrhythmias, which can also present with the same symptomatology. So ECG is very, very important. Blood pressure is also important because this blood pressure actually helps you exclude orthostatic hypotension. You would see that in rather than when they change position, the blood pressure rather than slightly dropping remains the same, or in some cases even goes up. Then you also might have to do neurological workup as well. So neurological workup obviously means that you might have to consider EEG or a full neurological consult, but at the same time certain blood tests would also help, like for example if you do serum electrolytes and serum glucose, that would help you because sometimes hypoglycemia and electrolyte disturbances because of hot weather or because of one or the other reason can also present with the same symptomatology. So checking serum electrolytes, serum glucose, calcium level, this is very, very important as a part of the initial workup. But if you're still worried that there might be some neurological underlying reason, a neurology or neurology consult is very, very important. They can later have an EEG or maybe an MRI as well. Now, coming down to the treatment. Now, treatment basically depends on so many factors. What you consider, for example, if you think that the child might be hypovolemic or might be not drinking well, you would give them the general advice that they should keep themselves well hydrated, they should drink plenty of water. Important thing is that they should not decondition themselves because this condition is associated with sort of these changes in upright position. The affected children might not like to move too much, and that further leads to deconditioning of the body, and that further aggravates the condition. So yes, they should avoid prolonged standing, but at the same time they should also keep on moving, because when they are moving the muscle pump also like kicks in action, and that would prevent most of these symptoms from appearing. So a little bit of light exercise is very important. They should keep themselves well hydrated. Number two, if the general measures do not work, then certain medications can help. Beta blockers, metoprolol or propranolol. So propranolol in a dose of 20 milligram per day can help. Sometimes the dose might have to be upped to a maximum of 80 milligram per day, but usually 20 to 40 milligram per day actually helps in calming down the tachycardia. Or you can use metoprolol somewhere between 2.5 milligram to 10 milligram per day. Fludrocortisone is another medication. It's a sort of a mineralocorticoid which actually helps retaining sodium in the body, increasing the blood pressure, retaining the fluid in the body, and that also helps in certain cases. 0.05 to zero 0.2 milligram per day of fludrocortisone can also help if they are not being controlled by propranolol. Then there are certain other medications, excuse me, like alpha agonist, midodrone. Midodrone is an alpha agonist that can be used, or there are certain other like types of alpha agonists that can be used under specialist supervision. But by and large, the most important drugs are beta blockers and mineralocorticoids. Sometimes they might have to be used in combination, but in most of the cases, propranolol and general measures should work. Resistant cases should be referred to the cardiologist so that they can be started under like some form of specialized medications to see if that helps them. So this was all about POTS. Briefly, I have tried to touch on the important features of postural orthostatic tachycardia syndrome, which is a very strange condition, very common these days, and you might have come across these conditions. Um, Most of these kids have been back and forth to the doctors because they've not been properly diagnosed, or they do not have been started on treatment, and they've got a very miserable life. So try to help them out, try to diagnose properly, and try to treat properly. I hope this video helps in making you understand what is postural orthostatic tachycardia syndrome. If you still have got any questions, put it down in the comment section below, and like I will answer them. Thank you very much. Take care, and bye bye.